Okay, very good, committee. We're going to go ahead and start the meeting. We're going to be here late tonight anyway, and so we might as well get moving. The first thing that I yesterday buried underneath some other papers, I do have one additional KDHE rec. KDHE is on the and here's my recommendation. The Department of Health and Environment shall establish a prospective payment system under the Medical Assistance Program for funding certified community behavioral health clinics. Such system shall permit payment by either daily or monthly rates. The Department of Health and Environment shall submit to the United States Centers for Medicare and Medicaid Services any approval requests necessary to implement this subsection. The Kansas Department of Health and Environment shall implement this section no later than May 1st of 2022. Do I have a second? Second by Representative Ruiz. Some of you have been hearing about the CCBHCs and the model that we're starting in the process. This is just the implementation of the language for that process to get us started. I think, was it Secretary Howard yesterday was telling us that there was 5 additional grants for CMHCs to start this program. We have one. We had one down in what is it, what's the one down? Fort County. There's Fort County already won. There's going to be 5 more. This is just starting that process. So further discussion on that? All in favor say aye. Aye. Opposed, same sign. Motion carries. Very good. Thank you. Thank you, committee. Sorry about not doing that yesterday. Anyway, okay, with that, we got a busy day here, and we're going to jump right into it. Matt Fletcher, Interhab. Matt, thank you for being here.
Some assembly required. I hope I'm in the right place. Mr. Chair, thank you for the opportunity to address the committee today and to discuss the ongoing challenges that the IDD service system faces here in the state of Kansas. And the challenges that are faced by our system are really due to two decades plus now of chronic underfunding for community-based services that support Kansans with intellectual and developmental disabilities. And there are 2 symptoms of that chronic underfunding which really have plagued lawmakers for some time. The first is an ongoing erosion of service capacity, the ability to provide support to those Kansans with IDD who are already in the system, already receiving service, but the infrastructure to provide those services is eroding, and that's due to the underfunding. The other primary symptom, in addition to that, is the state's waiting list of persons with IDD, which now totals more than 4,000 adults and children. And that waiting list has been allowed to grow since the late 90s. That was the last time that the state of Kansas had no waiting list for this population. And it's been allowed to grow to a number now it's very daunting. And I believe that there is no way that you could just simply pull out a checkbook and solve that problem at this point. It's just simply too large. So the members of Interhab have felt for some time that a strategic approach is really needed to creating a roadmap for resolution and elimination of the waiting list. And we are very hopeful that the legislature will take steps to establish some type of a committee process or a study process whereby you can really dig into the issues surrounding the waiting list and develop that roadmap forward. It's really needed. It's never been done. But going back to the first symptom that I pointed out, the erosion of service capacity, Service capacity for the community IDD system is really about the ability to recruit and retain a qualified direct care workforce. They're called direct support professionals, that's their title. And it's increasingly difficult for service providers to be able to recruit these individuals to perform this service. The work of a direct support professional is incredibly difficult, taxing work. It's often done without any direct supervision. It's often done with multiple individuals that person has responsibility for, all on their own, and it may include things such as toileting, bathing, feeding, or delivering medications to that individual. Wages for those direct support professionals average around $8 or $9 an hour in the state of Kansas right now. It's just simply not competitive, even with big box retail stores and fast food restaurants. And so we need to do something to help the providers to be able to recruit and retain. We want to close comments this afternoon by just saying thank you to this committee. You've really been leaders on this issue, and last year worked very hard to put money into the budget for a 5% provider rate increase. It's very appreciated, the work that you all did. Unfortunately, we lost those funds as a part of the mid-year allotments. We understand the unprecedented nature of the COVID pandemic, but we would ask that you would continue the work that you started last year to keep those funds going to providers. And with that, I'll stop and see if you have any questions.
Committee questions? Seeing none, I think you used up Nick's time too.
Goodness, apologies.
What is he
I'm new
gonna
here,
do?
remember.
Is Nick in here, or was he going to, all right, Nick, you got, Matt used up all your time, okay. So.
I'll make it very quick. So Matt talked with you about waiting list and rates for long-term care services. One thing that I do at InterHab is I facilitate an internal group around complex needs of people with IDD. So these would be behavioral health needs, medical health needs, or age-related conditions. And you know, a person with IDD, their long-term care needs are not likely to change through their life. If they need a certain level of services when they're young, they likely would need that when they're older. But their complex care needs would change a lot. And most of the folks who are served on the IDD waiver are at risk of institutionalization because of a complex care need, or possibly because of their IDD if they have severe or profound IDD. So we're working on 3 different things. I just want to keep the committee informed. One is around community-based care management. So coordinating for medical health care needs at a community level. Most of our members do this already, of course. A lot of them actually maintain essentially their own health clinics to try to get just a myriad of complex medical care needs met. We're also interested in pushing reform around civil commitment of people with IDD who have been who have gotten involved with the criminal justice system. So we think the community is the best place for them. There's a bill that would address a loophole in our civil commitment statutes that allow people to get indefinitely incarcerated, and it's a known problem. It's something we've been trying to get addressed for a long time, and we're working with members of the legislature and other stakeholders to take care of that. There's also a bill around behavioral health needs that would meet the crisis services needs of people with IDD around the state that will be heard on Tuesday in House Health and Human Services that we're trying to get a lot of support for. So with that, I'll sum it up.
Committee questions? Representative Lynn.
Thank you, Mr. Chair. I was just wondering, can you tell us those bill numbers?
The behavioral health bill is 2373. The civil commitment bill is still at the revisor's office. It's a bill that was, the Judicial Council formed a committee and they addressed the language in our civil commitment statutes. So now we're working with other stakeholders to try to develop ideas around what we can do to serve people better in the community. Yeah.
Thank you, Mr. Chair.
Very good. Committee, further questions? Nick, thank you for being here. Okay, next, Stuart. Very good, Stuart. Thank you for being here.
Thank you, Mr. Chairman. Stuart Little, Behavioral Health Association of Kansas. Testimony looks like this. Real briefly, I'll hit the highlights. We are an organization of substance use disorder treatment providers around the state, do a bulk of the SUD work and services. Community mental health centers are affiliated with your counties. These are for-profit, not-for-profit providers around the state. There's a map of them on the back on the last page. We are interested in, first of all, thanking you all last year for adding funds to, including the Medicaid rate increase and an increase that was provided for substance use disorder block grant recipients. These are people that are not poor enough for Medicaid, but the feds give us a small amount of money that then we use to provide some services, drug treatment services. COVID, the pandemic, has elevated the significance of substance use disorder issues in this country. It has the connections between employment, between child welfare, all those issues are a part of the work that the folks that I represent do. We've got a couple of things on this, on our testimony here. I'll save the time by just simply pointing out we would like to get restored what was approved by the legislature last year and taken back, which was $250,000. We'd also ask for another $250,000. So we get $500,000, which we use to purchase drug treatment services for individuals who are not Medicaid eligible and otherwise have no place to get services paid if they're uninsured. The second thing is we're still supportive of the additional rate increase for Medicaid rates for behavioral health services. I know that overlaps with a KDHE budget, and sometimes we talk about them together, but I know that's something that the community mental health centers are still advocating for. The one thing I would note is that the last point is not in your budget, but when you're sitting on the Appropriations Committee looking at issues, one of the things that is vitally important is the Senate Bill 123 program. This is a drug treatment program that diverts offenders from prison. You are looking at a variety of legislation this year that will add more people to that program. That money's handled through the Department of, through the Kansas Sentencing Commission, but since it is drug treatment, I'm trying to get some support. If you guys are going to pass some of those bills, the full Appropriation Committee needs to add funding to pay for that. Otherwise, we're going to grow the number of people in there with fewer dollars, and that'll mean actually less services. I'd be happy to stand for questions at the appropriate time.
Very good. Thanks, Stuart. Committee questions? Seeing none? Thank you. Next, we have Don Woodward. Don, thank you for being here.
My pleasure. Thank you, Mr. Chair and members of the committee. I'm the Speaker of the Kansas Silverhead Legislature and have been for the past 10 years. And we are the consumers. We're not a provider. We use these services, and we're all volunteers. We don't get paid by anybody. I want to thank the committee for last year's efforts in putting the $3 million into the KDAD's budget for the Senior Care Act. Unfortunately, we lost it in, I call it the reamortization, but we are back this year, and as critical as it was last year, that $3 million is even more critical this year. Again, it goes to the Senior Care Act, and it's for community-based in-home services to keep senior citizens in their homes rather than having to go to a nursing home prematurely. Now, there's 4,000 senior citizens currently using that program, and it's a cost-share program. So they're paying $3 million of their own money to be in that program. Now, in the year 2000, there were about 300,000 seniors in Kansas, and the budget was $7 million. Here we are in 2021, and we have about 668,000. That's 65 years of age and older, and we serve 60. So we're approaching 700,000 senior citizens, and it's still $7 million. And that's why you approved $3 million last year, and we would like you to add $3 million this year, and hopefully we can get it through omnibus, and the governor won't take it away this time. If you're unfamiliar, these services are in-home, could be attendant care, washing hair, giving them a bath, could be mowing lawns, could be doing laundry, dishes. It runs from $125 a month to $400 a month. The average is $250 a month. That's what it is for the 4,000 people in the program. And that compares to the nursing home cost to the state of $5,000 if you don't keep this service up. So if you're not moved by the moral aspect of it, just look at the financing. Do you want to pay $250 a month, or do you want to pay $5,000? I thank you, and I'll remain for questions.
Committee questions. Don, hang on just a minute here. I do have one question for you if committee doesn't have any questions. Don, what kind of wait list do you have now?
900.
900 on the wait.
And it's, you'll hear from KDADs and from the area agencies on aging that that can fluctuate because some areas, you know, there's 11 PSAs in the state. If you're a senior and you apply for it and you're told your share is going to be $50 a month and you say, well, I can't afford $50. Some of them keep you on the waiting list, but most of them take you off. So I personally think the 900 is valid, and I think it'd be a lot more if we ever go back to what Representative Ballard said of promoting the program. There used to be brochures. There used to be pamphlets that were sent out to the senior centers, and this encouraged people to get involved. They don't do that anymore.
Very good.
Thank you.
Representative Ballard has a question also.
Thank you. And you were addressing part of that, but how do you let people know about it now? So you've been there for 10 years, thank goodness. But how do you let other people know that they can do it and that it's not unbearable and it is effective?
Well, normally, not this year, but normally I'll get out and travel the state and go to senior centers and literally go anywhere, to churches. Strangely enough, that's probably the venue that invites me the most. Kiwanis Club, Optimus Club, Chamber of Commerce, anybody that'll let me come and talk, but usually it's senior-oriented, and we try and encourage them to at least call the Area Agency on Aging and find out about the program. I admit there will be seniors who would qualify, but they don't want to pay their share.
I'll just follow up with a question. Several years ago, I think it was the Topeka Capital, I can't remember which paper, did a big story on silver-haired legislators and highlighted them from the different areas geographically around the state. Would something like that be helpful, especially now with COVID and not all churches are meeting and you can't really go in big groups or anything like that?
Well, any publicity we could get to promote it would help. Unfortunately, the local newspaper never takes anything we give them. They always tell us we have to pay for it. We don't have any money. We can't pay for stuff like that. And they won't do it as a public service. Well, never have in the 12 years I've been here.
Thank you. I asked that question because I'm hoping some of them are listening today.
Thank you.
If they're listening, maybe they'll get a little hint that maybe they should try to reach out to the seniors around the state. Thank you very much.
Thank you. I appreciate the time.
Very good. Committee, further questions? All right. Thank you very much, Don, for being here. Next, we have Amy Campbell. Amy, thank you for Kansas Mental Health Coalition. Amy, thank you for being here.
Thank you, Mr. Chairman. I'm happy to be back before you to talk about the KDAD's budget. I've tried to organize my testimony in a way that is very clear and sort of in bullet points. If you'll look at this, our Kansas Mental Health Coalition is united in supporting the governor's behavioral health recommendations for enhancements for high-impact areas of need. I heard the secretary give a wonderful presentation yesterday about what those enhancements will do. The first one is $5 million for the statewide mobile response and stabilization. That's something that will really help the law enforcement officers that you all were hearing from on the hospital's budget. By having mental health professionals available to respond to the need rather than requiring law enforcement to always be involved in those calls. The $3 million for the family crisis response and support is in the DCF budget. The $0.6 million for community integration housing first program. This again helps reduce the pressures on our state hospital beds as it gives people a place to go when they are discharged where they can be safe within the community. We also accessed emergency funds during the pandemic to provide emergency housing for people who needed those services, and so this helps with that as well. All of these items were recommendations by the Mental Health Task Force and align with the recommendations of the Mental Health Modernization and Reform Committee. $2 million for community mental health center or specialized services in nursing facilities for mental health. This issue really gets into the weeds, and I am very happy to talk to each of you about why this is important. But to suffice to say that it helps to provide those services for folks who need to be able to achieve a level of recovery to transition back to the community. And that's something that we really need to be providing. We've been really falling down on the job on that for some time. That also was in the task force report. The emergency health, the electronic health record support is very important. The regional bed capacity contracts also. 988 is a topic that you will be hearing more about. There is a hearing on a bill next week. The federal government enacted 988 for a 3-digit emergency crisis line for behavioral health that would go to the National Suicide Prevention Lifeline number. We need to put some money into that network in order to make it work. It will happen in July 2022, whether we do anything or not. So the question is, will there be an effective response when people call that number or not? The estimates are that to set up a robust system could cost around $3 million. I have a section in here on the CCBHCs, which you have addressed through your proviso. Thank you very much, Mr. Chairman. And with that, I would be happy to answer questions.
Committee questions? Very good. You're off the...
Thank you.
All right. Thank you. Next, we have Mike Burgess. Mike, thank you for being here, Director of Policy and Outreach for Disability Rights Center.
Howdy. Well, thank you, Mr. Chairman. And it's a pleasure to be here and actually see your smiling faces. So many times I don't get to do that. So definitely something I don't take for granted. So I'll try and jump right in here really quick. There's 3 proposals that were part of the governor's or enhancements to the governor's budget that I want to add our support to specifically and call out to your attention. And ultimately, all 3 of these relate in some way, form or fashion to the nursing facilities for mental health, either to help divert people, help people while they're in there, or help them to transition out. And the 3 of those are in my testimony. The $2 million for community mental health center specialized services, and I know a previous conferee as well as the secretary covered the importance of that. My main point there is just to reiterate that federal law requires us to do this. We're not currently providing those in this setting. So this is a good start to be able to do that, an important piece. So definitely want to call that one out. The second one is the $5 million for statewide mobile response and stabilization. And again, that's to help divert people, to help keep people from having to go into these types of settings, whether it's an NFMH or one of the state hospitals. And the third enhancement is the $580,000 for Community Integration Housing First program. And again, this is to help provide those the housing needs for people to be able to transition out. And so again, all 3 of those are really important and wanted to call attention. In my testimony, and I think others have covered it too, what the specialized services are, as well as the citation of federal law, if you really want to get into the weeds on that. The 2 other items that I'd like to just quickly call your attention to would be to request, and a previous conferee talked about the needs on the IDD waiting list, the individuals with developmental disability. For a lot of folks, they will have been on the list. I feel like I'm cutting out. Can you hear me okay? Okay. Up to 8 or 9 years. And as you can imagine, someone's needs evolve dramatically from when you first apply. And so while the state, they know who they are, where they live, how old they are, various information, and they knew that when they applied that they meet that institutional level of care, but we don't know where they're at today. And so it's, I think, a good starting point as you begin to address that. And I do want to encourage and applaud the committee for their interest in either an interim committee or a task force on this. But I think to go along with that would be to have direct KDADs to do a study of the needs of the individuals on the waiting list. One thing that we know on that too is a lot of people, they're not coming onto or they're not starting services because their spot came up on the waiting list. Often it's because of a crisis. We're seeing more and more folks that way. And that's not good for anyone. They end up needing more services in a higher cost setting. And there's lots of trauma for the individual, obviously, if they're in a crisis, to start receiving services. And that may be because one of their caregivers gets sick or passes away. So there's lots of bad things that happen there. That's also something that we ought to study, because if we can anticipate when those emergencies are going to happen, maybe we can intervene ahead of time. The last thing that I'll do very quickly is, just as other conferees have said, and the secretary, the brain injury waiver, funding some additional slots to help with that. I think the state is beginning a process to look at additional folks to help increase the people to transition off. But we do know that we'll need some additional slots there to prevent a waiting list, because that would be very tragic if we ended up with a waiting list on that waiver specifically. So thank you, Mr. Chair. I'd be happy to stand for questions.
Committee questions? Mike, I might put you on the spot here. If you don't know anything about this, go ahead. I saw that the governor had pulled the VR Independence grant. Now, and I understand that that's ended.
Yes.
And so were there no people left to serve on it, or how did that work? Are you familiar with that?
I am. So one of the hats that I wear, so the Disability Rights Center is the client assistance program, and we help individuals who interact with VR. And as such, I sit on their committee. I would probably defer ultimately to the director of VR to talk specifically, because they're the ones who made that decision. I know there were some good things and some challenges with that program, and I think they're wanting to take those resources, I believe, and just go a different direction to see if they can better serve individuals. So, but Mr. Decker would probably be the best individual to answer those questions.
I'll get a hold of him.
All right.
Thank you very much. Committee, further questions? All right, Mike, thank you for being here.
Well, thank you very much.
We have Rachel Monger with Leading Age. Good guess, huh?
All right, I got the double mask on. Okay. Thank you very much, Mr. Chair. I am Rachel Monger with Leading Age Kansas, and we're the State Association for Nonprofit Aging Services. So in my written testimony, you have a whole array of aging services funding issues because our members do a whole array of those things. And is my microphone? Step back. Is this better? Is this better? Okay. Stop me if it's not. But we wanted to spend our few minutes here today to talk about nursing home funding. So in a nutshell, we strongly support continued rebasing of Medicaid nursing facility rates as set forth in Kansas statute. I'm sorry if Okay. We strongly support continued rebasing of Medicaid nursing facility rates as set forth in Kansas statute, especially in light of the extraordinary costs that nursing homes will continue to carry related to COVID-19 in the coming fiscal year. In addition, the 6.2% FMAP increase that's available to Kansas should be used to assist nursing homes with costs in the next fiscal year. So as a reminder, rebasing is what we're always talking about in the Budget Committee, and it's shorthand for how nursing home Medicaid rates are supposed to be calculated. And under law, nursing homes are to be reimbursed based on the average of their last 3 years' cost reports. And rebasing is the process of updating those cost report years. And that purpose of that is to keep costs somewhat close as possible to, current costs. So we're asking that the legislature continue to follow the rebasing law to update and fund our cost reports for 2018, 19, and 2020. Without the federal emergency funding we received, many of our nursing homes would have closed this last year or been unable to properly care for our residents. And because those emergency funds have kept nursing homes afloat, there will be an end date to that federal funding. And we believe that's going to be a steep cliff for a lot of our providers. So we're asking the legislature for enough Medicaid funding to help cushion the fall of our nursing homes. So even when the pandemic is declared over and life returns to whatever normal we're going to have, nothing's really going to return to normal for nursing homes, especially with costs. They'll have to carry increased expenses related to testing and testing supplies, PPE, sanitation, maintaining pandemic-related wages, hikes in staffing agency wages, and perhaps even physical environment changes. So due to the pandemic, the 2020 cost reports may be significantly higher in 2018 and 2019. We haven't actually seen them, but I think we can assume. But despite the anomaly that was 2020, we believe that the state should still proceed with and fully fund a nursing home rate rebase for 2018, 19, and 20. And because rates will be based upon the average cost of those 3 years, 2020 costs will only make up a third of the rate calculation. And keeping the 2020 cost report year can help form the cushion our homes need as COVID expenses stay high and federal relief funding is phased out further in 2021. And I will stop there, Mr. Chair. Thank you.
Any questions? Just as an overview of that, I think this committee had a 3% rebasing in there, but unfortunately it was put off to omnibus, and so that disappeared. And then the governor had a 1%, and it was allotted in July. So in other words, you didn't get any funding increases last year.
Yes, sir. We went, I believe it was a $30 million deficit that we went into the pandemic with.
Exactly. Okay.
Thank you.
Very good. Thank you for being here. Next, by WebEx, we have Jerry Machard, Developmental Services of Kansas. Jerry, are you there?
I am. Can you hear me?
And how bad did I butcher your name?
Michaud, it's French. Leave it to the French.
Very good.
Yes.
I knew it.
Thank you. Yeah, thank you, Chairman Carpenter and members of the committee. I do appreciate the chance to come before you this way. You know, I'm based here in Hays, Kansas, and we serve the 18 counties of Northwest Kansas. So it's a pretty big regional footprint. We've been around. We serve about 550 individuals with intellectual and developmental disabilities, and we've been doing this for a little over half a century. So I'm about 30 years with this organization, and you know, I'm grateful again for the opportunity to come before you and offer some testimony. If I had to summarize our need, and it's contained within my written testimony, is that you know, we've been serving individuals, and it's been a stressed situation given the rates. I think Matt Fletcher had mentioned a couple of decades or more where our rates have been mostly static, and we could talk a long time about that, but it doesn't take much thought to realize that when costs go up and your rates are established at a set point, you get into a challenging situation, and then you throw the pandemic into that, and you have a real stress upon stress. And so I wanted to say thank you for you know, the support. We're testifying right here in the KDAD's budget as our dollars through the Medicaid system flow through the KDAD's budget. Very much appreciated the actions of this committee last year with a 5% increase. Unfortunately, that tire never hit the road, and the need was needed then. Kind of goes without saying. You know, we're what the need is today. So you know, we remain diligent in our efforts to keep people safe. It's been a roller coaster. I think most would agree to that. Some of our workforce challenges are the key to this issue and the basis for the request for support. We have 36 open positions in 6 communities. When those positions remain open, you have stress upon the staff that remain. When you throw in positive cases of COVID and the responsibilities to separate and keep people safe and manage that, when you have vacancies in staff, the picture becomes a little clearer, and it's a difficult picture at that. We are grateful. We're working hard to adjust and respond, but we, unlike typical businesses, when costs rise, we can't raise our rates. We can't raise our price. That is through the legislative process, and again, the reason we're here today. You know, I would kind of close this thought with turnover at 44%. It's a little higher than the average across the nation, but that's way too high. Turnover in the midst of services for people who are vulnerable, people who require very, very personal supports. And if you have new people, you know, it's not hard for me to put myself into that picture and see how would I like a new person working with me, different people working with me and supporting me. That's kind of the human effect or impact on in all this. The turnover rates, we have those challenging needs, and as we look to try to find the solutions in all this, it really takes all of us. We're doing our best on the community side. The value of that community system is, we serve a lot of folks. I know we've talked about the waiting list, or it's been mentioned. That's another large issue. On the workforce challenge, I did a quick look at our unemployment rates throughout Northwest Kansas, and there are a number of our counties that are 1.7%. Yes.
Can you wrap it up very quickly? I hate to be that way, but we have about 15 more people in a bill hearing after this. I don't mean to be rude, but.
No, please, I apologize for running long. Two bills that are before the legislature, one with this committee, one in the Senate Ways and Means, House Bill 2046 and Senate Bill 154 target some concrete actions that the legislature can consider that might help us to address some of these systemic problems. And I thank you for your time, and I would take questions when that's appropriate.
Very good. Committee questions? Seeing none, thank you. Thank you for being here. And I might remind everybody that can hear, we just try to keep it to 3 minutes. I understand, but we want everybody to have a time to speak. So anyway, next I have Lori Feldkamp, Big Lakes President and CEO. Lori, are you there?
Good afternoon. Representative Faulkner, I appreciate the opportunity to speak before your committee and to all the committee members there today. A lot of my testimony would be a repeat of Jerry, so I'm going to try not to repeat a lot of what he said. I thought probably a good use of my time would be to outline what has happened to us during COVID, especially financially and in respect to turnover of workforce. We were very appreciative of the work that the committee did last year, getting this the 5% increase on our rates. And unfortunately, as you are well aware, that was cut. And I wanted to share with you that money does make a difference. For example, I've worked at Big Lakes since 1994, and in the past 27 years, rate increases have only been appropriated 8 times, which would average out to less than 1% per year. From 2008 to 2017, we had no increases at all, and our turnover during that same period of time went from 37% to 54%. Turnover is difficult under any circumstances, but when you have the inability to backfill open positions when people leave, that makes things that much more difficult. In 2008, the number of days it took for us to fill a position was 33 days. In 2019, it was 140 days. And as Jerry said very, very well, that adds a lot of stress to those that remain as far as providing services are concerned. So, of course, during COVID, we had experienced a lot of lost revenue. $1.3 million is what we lost in our normal revenue patterns that we have. We were able to qualify for the federal Paycheck Protection Program. We were also able to qualify for the CARES Act funding that came from Health and Human Services. And with those funds, our board decided to provide appreciation pay to our staff that were caring for our individuals and keeping them safe from COVID. As a result, we went from $11 per hour to $13 per hour from April until December when the money ran out. During that period of time, our turnover dropped to 24%. Now, I know there's a lot of other mitigating circumstances, but I think that it is very evident that increasing pay does make a difference as far as turnover is concerned. And this was an interesting study in that, considering what's been going on the last 10 months. I'm very proud of what our staff has done this past 10 months. It's been very difficult work. We've had positive cases. We've had death. That's not easy to deal with. But by and large, they've kept everybody as safe as they possibly could, and they put themselves and their families at risk by continuing to serve our clients. So with that, I'll just close and answer any questions that you might have for me, and I hope that you can go forward and continue to be supportive of the IDD population. Thank you very much.
Good, thank you for being here. Committee questions? Representative Ballard has a question for you.
I'm sorry, I can't hear you.
You indicated that your turnover rate was from 37% to 54%, and amount of times at one point took over 100 days. What do you do when it takes that long for over 100 to fulfill?
What we do is, unfortunately, then the staff that are here are working massive amounts of overtime, which of course is exploding our budget. For example, I have 35 full-time equivalent positions open at this time, so we are covering 1,400 open hours each week. What that means is that individuals that we already employ are working anywhere from 60 to 70 to 80 hours a week, which is just crazy, but that's what they're doing.
All right, so that's their overtime.
Yes.
All right, so you're paying them a higher amount for overtime?
Absolutely, time and a half.
Yeah, okay. Well, the reason I asked that is I know you were paying them, but what I want to say is that how long do you think people can keep this up?
They can't keep it up for long. In fact, I had, I think, 25 people that averaged 75 hours per week last year, and I've already lost 5 of them because of burnout.
Okay, that was the answer I was looking for. Because, yeah. I mean, you know you're going to pay them over, even though that money was nice in the beginning, but then you have to realize that they have to sleep sometime, they want to see their families sometime, and sometimes they get sick themselves. So thank you very much.
Very good. Thank you again for being here. Next, we have Colin McKinney with Starkey Inc. Colin, are you there?
Absolutely, Mr. Chairman. Thank you to you and the committee for making time this afternoon. Greatly appreciate the opportunity to talk about our services, as Jerry and Lori just did. I try not to duplicate what they're talking about. I will say that it sounds like the allotments that took place last year affected a lot of service systems beyond ours, and we get that. At some level, we can understand why those reductions were made. I can tell you that my employees absolutely do not. We passed a budget in late June. A few days later, found out that the budget that we passed that included rate increases for our employees could not go forward, and that we were going to have to resculpt it and take those increases back. We try to be cautious and not announce anything until it's a done deal. But certainly by the time our budget had been adopted by our board, our employees were aware of that. And honestly, they were mad about it. We, through the course of this pandemic, have repetitively pointed out how they are true heroes in saving and protecting lives of very vulnerable Kansans. And so with one breath, we're telling them how they are heroic in all the work that they do, all the overtime that they work, all the time that they put their personal health and safety on the line. But at the same time, they're thinking, you're calling me a hero, but you're paying me $10 or $11 an hour. It just doesn't make any sense to them. As Lori mentioned, having access to the COVID relief funds was helpful in maintaining the workforce the best that we could. We paid hero bonuses. We paid higher rates of pay for people who were working in settings where we had positive COVID cases. And that was certainly appreciated. But those who have hung with us do that because it's what's in their heart. And we do worry that they are going to burn out. We cannot continue to ask them to work these types of hours in these stressful situations for extended periods of time. It just can't move forward. While we've been stressing over that, we've been trying to get people vaccinated and looking forward to a post-COVID reality. We now have this new thing coming down at us from Washington, D.C., as there seems to be some steam behind a $15 an hour minimum wage. That's a long ways from where we are right now. If the new minimum wage were $15 or $12 or $10, we would have to pay significantly more than that because we have stressful, challenging jobs that require a professional level of performance. And if you could go do a very simple job and make the same pay, you would do that as opposed to the types of challenges that we offer. So keeping in mind that I believe some sort of minimum wage increase is going to happen, we need to go beyond the restoration of the 5% that was taken back out of the budget last year and start planning for a future where we're paying our employees an appropriate living wage over the long haul so they can continue to do this work and not have to look at other types of work that are going to be easier for them. Again, I greatly appreciate your time and would be happy to answer any questions you may have.
Questions? Seeing none, thank you, Sean. Thank you, or Colin. Thank you again for being here. Okay, next we have Sean Sullivan, President and CEO of Midland Care. Sean, are you there?
I am. Can you hear me?
Yes, we can.
Good afternoon. Thank you, Chairman Carpenter and members of the committee. Just want to, I don't want to reiterate what I provided and presented a week or two ago on behalf of the PACE organizations or programs in Kansas, but just want to highlight one or two things quickly. And with Midland Care, we are a senior services provider in Northeast Kansas. We do provide a number of services and programs, including the program for all-inclusive care of the elderly, or PACE for short. PACE is a managed care system for seniors that are over 55 years of age and that are certified to need nursing home level type of care. So as I presented to your committee a week or two ago, there are a couple of recommendations that the PACE programs have to reduce barriers to entry to the program and to help grow the program and make it more robust. I won't cover each of those because I know that you all are having a bill hearing next week, early next week, on one of those, at the protected income limit. So I just want to highlight one thing, and that is our recommendation and respectfully request to add in to the human services caseload process, the PACE program expenditures. And as a reminder, part of our PACE expenditures are in the caseloads that are updated twice a year. Part of them are out. Several years ago, going back to 2012 and 13 timeframe, all the expenditures were in. And then when the enrollment cap for PACE was taken out as CanCare started, then that caseload process changed for PACE. However, since, as I mentioned to the committee before, as we have learned since then, we know that PACE saves the state money, at least 10% for every person that we serve through PACE instead of CanCare. And by inserting PACE back into the caseloads, it provides greater enrollment certainty as the PACE program grows here into the future. So we would respectfully request that the committee include this in the recommendations. The only other thing I want to mention is that we also are a Meals on Wheels provider and do provide over 200,000 meals to our corner of the state a year. I do understand that there was and is a $850,000 recommendation from the governor in the KDAD's budget for a reduction for the state general fund for Meals on Wheels. However, in conversations with KDADs and the area agencies on aging, my understanding also is that $850,000 reduction will be offset by CARES Act and stimulus money. So our belief and my belief is that's essentially moving funding from one pocket to the other, and what we made whole will be fine, and there won't be a reduction in the number of meals provided. And through that would hope and just ask to keep that on everyone's radar for coming years or next year when that is not possible and when there's not stimulus money likely to use for that program. So with that, thank you for the time and thank you for what you all are doing, and appreciate your committee. Thank you.
Thank you, Sean. Committee questions. Representative Ballard.
John, just a quick question. You indicate there's over 200,000 annual meals, and I'm not pulling up the budget right now. What's the annual budget for Meals on Wheels?
Well, that's 200,000 meals that we provide as an organization. There are many other meals and nutrition providers in Kansas. I don't have it in front of me. I could pull it up in the budget report quickly, but I think it's millions. 3 million for some reason is sticking out in my mind from years past. Something like that. So,
and your 200,000 is still based on donation if they are able to pay?
Yeah, so nutrition and Meals on Wheels traditionally is funded through a couple of different sources, through federal funding, state general fund money, local funding, but we also do ask for donations, as you mentioned.
Okay, thank you. Thank you, Mr. Chairman.
Very good. Committee, further questions? All right, Sean, thank you. Thank you very much for being here. Next, we have Kyle Kessler, Executive Director of the Association of CMHCs of Kansas. Kyle, welcome to committee.
Thank you, Mr. Chairman, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We represent all licensed 26 CMHCs around the state, and we appreciate the opportunity to provide testimony on the KDAD's budget this afternoon. I'll be brief with my comments. We really have three specific things to mention. One is that we absolutely appreciate the enhancement recommendations in the governor's budget relating to housing services as well as mobile crisis response services and mental health services for persons in nursing facilities for mental health. These are three really important areas that were highlighted in the Mental Health Modernization and Reform Committee. They are also issues which are funding pieces that connect to the future of the CCBHC, or Certified Community Behavioral Health Clinic Initiative, which was also a high recommendation from the Mental Health Modernization and Reform Committee, which will also help us with our moratorium at the state mental health hospitals, which we talked about 10 days ago. And just as an example, during that time that has passed since I was last in front of you, I think the waiting list at Osawatomie State Hospital has gone from 22 to 30. This is just unsustainable for our communities. And so any relief that we can get through these initiatives relating to CCBHCs or even these pieces of the governor's recommendations are very important. Next, we would request the restoration of the funding that was a victim of the allotments process last year, which was the 2% Medicaid rate increase and the $2 million for the CMHC contracts. We appreciated this committee's work on that last year very much and would love to see that restored. Lastly, in part thank you and part request, we appreciate the attention to the proviso for KDHE's budget on the CCBHC prospective payment system that you all voted on right at the beginning of this meeting. That's a fantastic step. And then the second part of that would be proviso language for the KDAD's budget, compelling them to do a certification process or establish a certification process for CCBHCs. Those are both parts of House Bill 2160. So this provides us with a safety net in the event that we have any challenges getting the legislation through, or if there ended up being some challenges that occur through the pandemic and for some reason the session gets shorted some. But we believe that the startup costs are in the $4 to $5 million range for the CCBHC initiative. And I will stand for questions at the appropriate time. Again, thank you for your consideration.
Questions? I think you must have done a great job, Kyle. Thank you. Thank you very much for being here.
Thank you, Mr. Chairman.
Okay, next we have Janet Williams, Brain Injury Association of Kansas and Greater Kansas City. Janet, are you on?
I am here.
Very good. Thank you. Welcome to committee.
Thank you for having me. I'm here to talk to you today about the brain injury waiver. You may or may not have been receiving some emails from folks. In 2019, the legislature changed the definition of brain injury to include acquired and children, which was a fantastic move that we had been looking for the previous 28 years. That has been a resounding success. As you may know, the brain injury waiver is a time-limited rehabilitation waiver with the average amount of time anywhere from 2 to 4 years. People transition to either another waiver, completely off Medicaid, back to work, and people have great success on this waiver. Money was not added to the budget when the definition was changed, and we knew that at some point more money would be needed. At the same time, in Wichita, there were no services, and the MCOs got together and decided that that needed to be fixed. And so services expanded to Wichita and statewide so that there would be a better network for people. All of these things combined have led to an increase in the number of people. People are not transitioning off as quickly as before because of COVID. And so now KDADS is working with stakeholders on some really good policy changes and accountability measures. And so Our ask for today is that the brain injury waiver, people on the brain injury waiver be considered in the consensus caseload, and that we work with KDADS on a review and revision of policies for additional accountability. I have written testimony there that has a whole lot more, but I was just trying to keep it as brief as possible, and I am happy to stand for questions.
Very good. Thank you. Committee questions? Seeing none, we will review your testimony.
Thank you.
Okay. Thank you. Thank you for being here. Next, we have Margaret Farley, Executive Director, Kansas Advocates for Better Care. Margaret, are you there? Margaret? Okay, maybe she'll come back on here in a little bit. Okay, I'll move on down. Steve DeVore, Chief Executive Officer, Kansas Suicide Prevention Headquarters. Steve, are you on? Okay.
Yes, can you hear me?
Yes,
Nope.
very good.
All right. Well, sorry about that. Chairperson Carpenter, members of the committee, thank you very much for the opportunity to be here. As mentioned, my name is Steve DeVore. I serve as president and CEO of the Kansas Suicide Prevention HQ, formerly known as headquarters here in Lawrence, Kansas. We are the largest and most comprehensive suicide prevention organization in the state of Kansas. And we're also the only suicide prevention organization that that provides resources and services to all 105 counties in the state of Kansas. We are the Kansas provider for the Lifeline services through the National Suicide Prevention Lifeline, serving the entire state of Kansas. However, we do partner with an organization called ComCare out of Wichita, who serves directly and exclusively to the residents of Sedgwick County through the Lifeline. We're excited to be able to announce that Johnson County will soon have a similar situation where they'll be helping out residents within just Johnson County. I wish to echo some of the comments that were made earlier from Amy Campbell, representatives from KDADS, and even Kyle Kessler recently, who feel as passionately as we do about wanting to make sure that we're providing services to individuals struggling with various mental health conditions and potentially find themselves in a mental health or a suicide crisis. I want to reiterate that 988 is happening, and it's happening right now. It's no longer if it will happen, it's no longer when it will happen. It is happening right now. Kansas received approximately 20,600 calls into the Lifeline through the NSPL in 2019. 20,600 just from Kansans. Vibrant Emotional Health is the organization that owns and manages the National Suicide Prevention Lifeline and coordinates their network of call centers. They estimate that once 988 becomes fully operational for all carriers, over the next 5 years, we could potentially see a 300 to 800% increase in call volume. To be able to put that into context, there could now be between 60,000 and 164,000 calls just from Kansans coming into the 988 call line. We want to strongly encourage and support a $3 million enhancement to the KDADS budget to fund capacity building specifically for this crisis and lifeline services. Currently, there's a House Bill number 2281 in the Health and Human Services Committee requesting funds for this same purpose. But out of an abundance of caution, should that bill encounter any setbacks or modifications, an alternative funding source will be vital in meeting the needs of all Kansans suffering through a mental health crisis. Lastly, 988 is so much more than just a 3-digit phone number. I want you to visualize this. 988 is now going to be a shiny, bright front red door that serves as a beacon of hope for anyone in need. By dialing 988, individuals will now have walked through that shiny front door and will be met with immediate, evidence-based, real-time assistance, continuing through the crisis continuum of care, resulting in possibilities that can range from mobile crisis response to local assistance within their own community mental health centers. All Kansans must have the confidence in knowing that red door will stay open, that phone call will be answered, and the crisis continuum of care stands ready to accept anyone at any time during their darkest struggles. Thank you, and I'm happy to answer questions.
Committee questions? Thank you very much. We will take a look at your testimony and consider it. Okay, did Margaret Farley ever get on here?
Yeah, yes, can you hear me?
Yes, we can.
Oh, good. My apologies for that. I think I must have been muted on my screen. Thank you, Chair Carpenter and members of the committee. I am the Executive Director of Kansas Advocates for Better Care. We are a 46-year-old organization, and we've been dedicated the entire time to improving the quality of way back when nursing home care. We've added assisted living care and home and community-based services as the industry has and the needs of Kansans have changed. We are here today to make a pitch for sufficient dollars and increase in money to the adult care home survey programs within KDADS. These survey programs are critically important. We have all seen the massive injuries and deaths that have occurred during the COVID pandemic. Surveys and inspections are coordinated through the regulations that are in place, both in federal nursing home reform law and state regulations. And both of those areas of the law are intended solely to protect the health, safety, and welfare of the people that providers of long-term residential long-term care are providing. If they are not complying with those regulations, there is a risk of injury to the individual residents. That is the purpose for the surveys, to keep the facilities on target with following the regulations that are meant for the health, safety, and welfare of residents. And that program of the survey program has been eroded over the past several years and was completely overwhelmed during the cutback on surveys that occurred in last year. There's a great need for additional surveyors. I believe that they are still short in the neighborhood, close to 15 or 17 surveyors. Adult care homes that are the assisted living type facilities, there is not nearly enough surveys in terms of the frequency and the extent of the surveys. Some of them are, these facilities aren't even surveyed physically when they open up. These are key programs. I know that the industry feels that they're difficult. They're meant to be because they're protecting people who live in long-term care facilities. They're also, we heard a conversation earlier about increased funding for adult care homes. It's also a way to hold the federal and state contractors to certain standards, and that's what the surveys do. And so we would just strongly encourage that program be strengthened and that program be adequately funded. And I'll stand for questions. Thank you.
Very good. Thank you. Committee questions. Thank you for being here, Margaret. Next, we have Laurel Alcree, Executive Director, Senior Services of Wichita. Laurel,
Yes,
are you there?
I am. Can you hear me?
Yes, we can.
Laurel Alkire, but I've been called a lot of things, so that's okay. Thank you for allowing me to testify this afternoon. I am the Executive Director for Senior Services in Wichita. We are the Meals on Wheels people here in town. We do home delivered meals. And I'm also the chair of the State Meals on Wheels Association, that works together to take action on issues that affect our programs and the seniors we serve. It was mentioned earlier, I think by Sean Sullivan, that the governor's budget for 2022 includes an $850,000 decrease to senior nutrition. And I learned at another committee meeting on Tuesday that they do plan to use the COVID dollars for that. So we just hope that that happens. Because statewide, that would affect about 525 clients with that kind of loss. Here in Wichita, we can feed one senior for a full year at about $1,940. Many of these people have no other sources of assistance and would probably end up in state-funded nursing homes at a much higher cost to the state. I do want to share with you that COVID has changed everything for us, and we never missed a meal. Our seniors never went hungry from the time everything shut down throughout the year. Staff worked hard to figure out a different way of doing service. We did get some COVID dollars. Most of that was used to cover the additional shelf stables for days when we did not have enough volunteers to deliver. And over 3 months, my staff assembled 20,000 shelf-stable meals to make sure that there was food in their house if we could not get there. We also lost volunteers, but we're very fortunate when schools closed down that teachers and others stepped up to help us. And I'm very happy to say that that continues to this day. Our volunteers are fabulous. They showed up in this freezing weather, make sure that we could feed our people. We have had to change the way we do deliver. Now the meals are put in a plastic sack, tied to the door, sat by the door. Volunteer knocks and step back 6 feet. We want to make sure we see them because a big part of that is their safety check, but there is not a lot of interaction going on, and that's unfortunate, as these people are some of the most isolated in our communities. So anyway, just saying, we did use COVID money for masks. All of our volunteers have masks. They have hand sanitizer every day. They're offered gloves if they want them. We have to keep both our clients and our volunteers safe. Our clients are invisible to most people. They are truly homebound. And for many, they have not left the house since this whole pandemic hit. They haven't even been to the doctor because they're afraid. Their families can't come in. Trying to get them vaccinated is going to be a huge endeavor because many of them are not mobile. But again, I just ask that you keep an eye on this, as Sean also recommended, and make sure that we can feed all of our seniors. And thank you. And if you have any questions, I'll be happy to answer those.
Okay, very good. Thank you for being here. Committee questions. Okay, seeing none. Next I have Sean Balke. Sean, are you on?
I am. Can you see and hear me?
Yes, we can.
All right. Well, Chairman Carpenter, members of the committee, thank you so much for having me today. I think many of you will be familiar with the focus of my testimony. Matt Johnston with Maxim Healthcare Services and I, as I'm President and CEO for Craig Home Care, have presented numerous times and with some success. We appreciate the support in the past. Like so many conferees on here, we experienced not full success, but some success with our requests last year, only to have that obviously taken away. And so we didn't get to realize any of that. And the purpose of my testimony today is to rehash and regurgitate so much of what you already know about the request for the increase to the FCMC for specialized medical care rate in Kansas. Matt Johnston, who I believe has testimony as well, is going to cover that in detail. My focus, and very briefly, is just to provide some additional emphasis and data points for the impact that this issue is having on rural Kansans. My organization is the only one that provides this service, the specialized medical care service, across the entire state of Kansas, and we've done this since 1994. And the difficulty and pain of what I've observed over that period of time is a degradation in service and just a real critical limitation on access to care for those people that live in rural communities outside of Kansas. To give you some idea, so We have roughly 118 right now active cases across the entire state. And if you scroll down a little bit and look down on the second page of my testimony, you can see a map that demonstrates that those aren't going to be unique patients, but those are locations where we have patients. There could be more than one in some of those dots that are on that map. So we have 118 that are considered rural. That means they reside outside of a metro area in Kansas. And on average, we're able to provide only about 50%, or 54% of the hours that their physician authorizes and that the MCOs in Kansas feel are appropriate to ensure that those medically fragile children can come home from acute care hospitals and stay there. And we know that, like many other programs, that, you know, when the home-based care for this population, like so many others, is the absolute lowest cost setting to care for these kids. And we have so many that are out there needing care, they don't get it, they go back. Or, like, if you look down further in my testimony, I believe it is the fourth bullet point there under key statistics. Right now, we have about 51 cases that, some of those, it's a mix. Some of those are cases that have never been discharged before from the hospital. Others are cases that have been discharged and they've been on service, but they had let's say a surgery, or they had an illness and they had to go back to the hospital. And during that time, the nurse couldn't wait. And so we lost that nurse. So now we're recruiting and trying to find a replacement. So we have roughly 51 referrals that are waiting to come home for this level of care. And at that time, they're getting, you know, that expense that they're incurring is at a rate that is about, well, somewhere between $2,400 to $4,400 a day. Whereas typically for us, they're going to be, you know, if they're on our services, around, you know, $400 to $600-700 a day. So significant difference in cost. And that's racking up day by day, every instance that this occurs. So you add on top of that the distance issues. You know, we have so many amazing nurses that they're wonderful. They'll, instead of working at a clinic or an institution, a hospital, and maybe it's more closer to home, they'll suck it up and they'll try to drive 50, 75 miles sometimes one way to care for some of these children. They just can't continue to do this. They're making pennies on the dollar at times for what they can make in other settings. We simply can't compete. And this service is at an absolute crisis. I can't, under the current reimbursement model, I can't continue to operate a business that loses. And that's everything that we're losing. We can't continue to sustain that. I have an office that employs 53 employees serving 45 children families in Western Kansas that I don't know that I'm going to be able to maintain. It's been on the bubble for a while, and now it's pushed over that ledge, pushed over that point. So my request is to encourage you to support the request to increase the SMC rate from where it is at 3156 to the 47. We need it desperately and appreciate your support in that. And I'll stand for any questions.
Questions? Just for clarification, Sean, is that what I call, in my limited knowledge, the T1000? Yes, it is the T1000 code. It's the SMC service on both the TA waiver and the IDD waiver. Okay, very good. All right, thank you very much for being here. Yep, thank you. All right, next I have Mark Dugan with Dugan Consulting. Mark, are you there?
Yes, sir, Mr. Chairman.
Very good, thank you.
Oh, yeah. You got me, sir?
Yes.
Okay. Mr. Chairman, thank you for the opportunity to be here. Members of the committee, my name is Mark Dugan, and I'm here testifying in my individual capacity today. In my written testimony, I've included the story of how my 6-year-old daughter, Joyce, suffered a traumatic brain injury around 4 years ago. 4 years later, she has slowness on her left side, continues to suffer from ADHD, impulsivity, and some other things, but she's also the most friendly, fun kid you'll ever meet. Also included in that testimony is a story about Mason. We met Mason at Madonna Rehab Hospital in Lincoln. Mason had a stroke during surgery. Prior to the change in the definition of the waiver, someone who was struck with external force like Joyce would have qualified for services, but someone like Mason would not have qualified for services. You fixed that problem in 2018, and for that, thank you. But I'm here to talk to you today about another issue with the brain injury waiver that needs your attention. First, just know that Joyce has not received services for the waiver, and we don't believe she'll need to. Due to private insurance and support of friends and family, we've been able to make things work. That said, without your intervention, the brain injury waiver is about to be rendered useless and a massive waste of money. You see, the brain injury waiver is different than every other waiver you fund here. It's a rehabilitation waiver. People go on and then they come off. Due to Joyce's continued disabilities, she will be eligible for the IDD waiver for the rest of her life. But because she received intensive therapy and rehab for 2 to 3 years after her injury, we're optimistic she'll never need it. A waiting list would negate the main benefit of the rehabilitation waiver during the very time that the brain is healing and learning new workarounds through a process that people who know a lot more about these things than I do call neuroplasticity. And I say this with absolute seriousness, and I'm sure many of my fellow advocates would disagree. If you're going to have a waiting list for the brain injury waiver, you might as well consider eliminating the whole thing. Because the state would be providing rehab services after the time a person is best able to rehabilitate their injury. What can you do? Due to the unique nature of the brain injury waiver, we feel it is better placed in consensus caseloads, thus negating the possibility of having a waiting list. But in transitioning to caseloads, we believe it demands more aggressive legislative oversight. And why do we think that's the case? The reality is the brain injury waiver is just one of a long list of things KDADs must worry about. It isn't in the news, there aren't rallies for the victims, and there aren't a bunch of advocates holding them accountable. Said another way, our wheel isn't very squeaky and therefore doesn't get much grease. I know and respect the people who work at KDADs. Michelle, Brad, Amy, Scott, Janice, and Secretary Howard are all great people who do this work for the right reasons. But the fact that this week is likely the first you've heard of this issue and the waiting list issue, I think makes our point that it is not at the top of anyone's priority list. So if you do make the decision to put this in the caseloads, we have attached to this testimony, I've included some items that the administration, you should ask the administration by proviso to provide quarterly to the CanCare Oversight Committee. In closing, up until 2 years ago, the only location for specialty services available to serve Kansas with a brain injury was in the northeast corner of the state, and it was only available to those with a brain injury by external force who were over the age of 16. Your leadership in the past few years has been admirable and make Kansas a better place. Thank you, and I'm happy to stand for questions.
Question. Representative Lynn has a question.
Thank you, Mr. Chair. I was wondering if you could address the cost of what it would be if we moved the brain injury list to caseloads.
I think the administration provided some funding requests in the governor to the governor that were denied. It's my belief that those numbers are larger than they will eventually be because just, I guess, this week, Janice could confirm that this week or last, they rolled out some items that would tighten moving folks off the waiver after they have had their rehabilitation. I don't believe those were in place or contemplated at the time they submitted those budget numbers. So, for example, Representative, there's 100 people on this waiver that have been on there over 6 years, and 270 people who have been on this waiver over 3 years or more. And if it is truly a rehabilitation waiver, it is important as we bring more folks on that we also transition folks off into other programs that are more appropriately suited for their services. So I think that number is less, and I think it's also a very worthy expense.
Thank you, Mr. Chair. I would agree. I think it's very important that we take care of this.
Very good. Committee, further questions? Thank you, Mark. Thank you for being here.
Thank you.
Okay, next we have Natalia Sandate, Executive Director of Ember Hope Youthville. Natalia, have I butchered your name?
It's okay. Natalia Sandate. Can you see me and hear me?
Very good. We can.
Okay.
Thank you for being here.
Thank you, Chairman and committee. Today I'm here to talk with you about a request that we had actually advocated for and received support for last year to the tune of $1 million to advocate and allow us to provide a multi-year pilot program for PRTS services, and those are psychiatric residential treatment services for youth. Youthville, Ember Hope Youthville is a child welfare nonprofit agency. We're located in Newton, Kansas. We have a 90+ year history of providing services, and I've been with the organization for over 20 years. Recently, in 2019, there was a research paper done on PRTF services and how best to move forward in terms of closing the gap to ensure that both value as well as recidivism, the wait list, just a number of issues that were year after year problematic for children waiting and families waiting for this level of service. We felt committed and passionate enough to not just open a PRTF and do what has been done, but actually address the findings in the research that were outlined. And these are both short-term and long-term findings. And the committee was last year generous enough to support our request, and we again are back in front of you to ask for your ongoing support. We really do feel like we can close the gap on both the waiting list and some of the necessary aftercare services to create a value-based program that will really address the recidivism for children returning to psychiatric services. I appreciate your time. I know there is a lot of people here asking for money that was probably retracted last year due to the pandemic. And so I stand for questions that you may have regarding this testimony.
Very good. Committee questions. I just might, I think, don't you have, isn't that the 12-bed?
Yes, correct.
Okay.
Correct. It is going to be a 12-bed facility. We're going to focus on females specifically. This program is really designed to work with children who are at risk of coming into custody. They aren't currently in custody, but this seems to make up the largest group of individuals, of children on the waiting list. And we just really are committed to addressing what we see as the ongoing issue around this group on the waiting list.
Very good. Thank you, committee. I might remind you that Secretary Howard did mention that yesterday in her testimony. So just as a heads up, that's exactly what she was talking about. Very good. Thank you for being here.
Yes, thank you.
Okay, next we have Matt Johnson, Director of Business Operations, Maximum Healthcare Services. Matt, are you there?
I am here, Chairman. Can you hear me and see me?
I can. Thank you.
Awesome. Great. Well, Chairman Carpenter, committee members, thank you very much for allowing me to speak today. Thank you, Sean Bakke from Craig Home Care, for getting us started on the specialized medical care issue. Once again, my name is Matt Johnston, and I work for Maximum Healthcare Services. We are a provider of specialized medical care through the TA waiver and IDD waivers. Specialized medical care refers to nursing services that are provided in the home to severely injured pediatric and adult patients. I am here to ask the committee for an increase in reimbursement rate from $31.56 to $47. The current rate is one of the lowest in the country, and it hinders us from being able to recruit, train, and retain nurses that will provide this vital service within our communities. Currently, around 65% of the state authorized services are being provided. It is the equivalent of a doctor telling someone that they can only receive 65% of the medication that's going to make them better. These are necessary services that these patients need to survive and thrive in the community. With the current reimbursement rates, nurses are having to take 60 to 70% of the pay they would receive in any other healthcare setting. Nurses want to work with these patients in the home, but cannot take that type of financial hit. Over the years, Maxim and other specialized medical care providers in the state have advocated for rate increases, worked collaboratively with the legislator, KDADS, and KDHE, and have identified multiple avenues to fund the increase. First avenue is the legislator could request caseload transfers from KDHE Medicaid budget to the KDADS budget. This would make the cost of the increase revenue neutral based on all the research that we've done. due to reduction in hospitalization days from specifically the specialized medical care patient population. I'm happy to provide these calculations if any legislator would want to see them. The legislator could, number two, the legislator could allocate new state general funds to the appropriate waivers within the KDAD's program. It's estimated the cost of the increase would be around $9 million in state general funds. The legislator could also do a combination of both of those, caseload transfers and new state general funds. Our research has concluded that it would take about a 1.02% reduction in hospitalization days from just the SMC population to cover the cost of the increase. Think about a patient, one of our patients who spent their first 637 days of their life in the hospital. Then knowing that patient could have been home for over 200 of those days, but they had to remain in the hospital because there was no support for them in the home. There are over 600 Kansans that receive this service. Imagine the cost savings that the state could have if specialized medical care was provided at the level that it was supposed to be. I've worked for Maxim for 14 years, and I've been honored to meet some of the strongest patients and families in our communities who require this service. As a parent, I know the excitement you experience the day your child is born. Many families on the TA waiver and IDD had the same feelings until their life was changed forever when a doctor told them something went wrong. Many of us worry about our kids being safe at school, being safe with babysitters, being safe with family members. These families have to worry about their kids staying alive when they leave the home. Please increase the specialized medical care rate to $47 per hour for fiscal year 2022, using any funding mechanism necessary. I also, just one other note, there is written testimony from Addie Begley, who is the nurse practitioner from Children's Mercy Hospital, who gives a hospital's perspective on this issue as well. Thank you for your time, and I'm available for any questions the committee might have.
Good. Thank you very much for being here, Matt. You're no stranger to our CanCare Oversight Committee meetings.
Great to see you again, Representative.
Committee, further questions? Okay, next we have Linda Mowbray with President and CEO of KHCA and KCAL, which I have no idea what that is. But anyway, Linda, are you there?
I am here. Can you hear me, Mr. Chairman?
Yes. Maybe you could elaborate on what that acronyms are just for us.
Absolutely. Kansas Healthcare Association and Kansas Center for Assisted Living. We're a trade association that represents nursing homes and assisted livings across the state. We have for-profit, not-for-profit ownership. We have independent owners. We have corporations. Our membership is very broad-based. Today, I'd like to talk to you a little bit about the budget situation for the nursing homes. I am sure that you are all painfully aware of how bleak our situation is with our Kansas nursing homes. You know, there has been a tremendous amount of talk about the pain and suffering that the residents have gone through, and that is so true. The staff in the nursing homes have gone through nearly as much. The death, the loss of life has been incredible, not only of residents, but we've lost staff too, family members. It's been a very difficult time. Adding to that, the financial burdens of wondering how sustainable the profession is has made it a very difficult climate for our members. You know, it wasn't too terribly long ago that Kansas could boast there were 150 counties and there was a long-term care option in every county. We're down to 99. So there are already counties where there's not a skilled nursing home or a long-term care hospital as an option. We really need to fully fund the nursing homes. As my colleague Greg Cholmonger had stated, we are fully in support of a rebase. If you think of it this way, you're looking at what you paid for a loaf of bread in 2019 or 2018, 2019, and 2020 to figure out what you're going to pay for that loaf of bread in 2021. It's so important that we get the numbers right and that we fairly fund our homes. Additionally, assisted livings have suffered tremendously as well. HCBS funding is so important for them, whether it's keeping the 150% of SSI for the protected income, or keeping access to home and community-based services for them. I will say that the nursing home profession has suffered. There's no doubt about that, but we are counting on you to look at the options that are available. I think in my testimony, I outlined some programs that might be helpful, also identify some money sources, and I will be happy to stand for any questions and be a willing partner to work with all of you to try to fund the nursing homes and take care of our elders in Kansas. Thank you so much.
Very good. Thank you for being here. Committee questions? All right. Thank you, Linda. Committee, I'll bring your attention to written testimony from Addie Begley, Children's Mercy Hospital that Matt mentioned, and Ryan Reza Nami. Any further questions? Okay, well, we'll close the hearing on public testimony for the Kansas Department of Aging. And we'll open the hearing on House Bill 2250. With that, Saylor, are you going to? Not Saylor. Are you going to give us an overview, or is there somebody going to give us an overview of this?
Mr. Chairman, this is Scott Abbott with the Revisor's Office.
Scott.
I'd be happy
Hey,
to brief
Scott.
the committee on the bill.
Should have known that. Very good. Thank you for being here, Scott. Give us a little overview on the newborn screening bill.
All right. Thank you, Mr. Chairman, and good afternoon, committee. House Bill 2250 makes a few changes to the newborn screening statutes that impose a number of duties on the Department of Health and Environment, as well as physicians and healthcare facilities in the state of Kansas as they pertain to newborn screenings. The first change is to eliminate the current list of conditions that is enumerated in statute. You can see that list of conditions on page 1 of the bill in lines 19 and 20. I'm not going to embarrass myself by trying to pronounce any of those, but you can see what those are currently enumerated as in statute, and would instead require the Secretary of Health and Environment to establish the list of conditions that would be included in newborn screening. The Secretary currently has authority to include some conditions in newborn screening and for the information and services provided for conditions that may affect newborns, but this would put all of that authority essentially in the Secretary of Health and Environment's hands. The one restriction on that is the Secretary determines the conditions included, but that includes at least the conditions listed in the recommended uniform screening panel that is recommended by the United States Secretary of Health and Human Services. So at least those conditions would be included. The second major change that the bill would make to the newborn screening program is for the reimbursement of medically necessary food products for persons who require them for these conditions. Currently, there's some enumeration as to the limit that may be paid or reimbursed for some of these products. The bill would put that also in the discretion of the Secretary to develop guidelines and rules and regulations for that reimbursement. The third major change is to the funding of the newborn screening program. Members of the committee may remember from last year in the budget bill, the transfer from the medical assistance fee fund to the newborn screening fund was increased from $2.5 million to $5 million for the current fiscal year 2021. But because that was in the budget bill, it was only effective for the current fiscal year. The bill would make that increase to $5 million per year on a permanent basis. So, Mr. Chairman, the rest of the amendments in the bill are kind of conforming to that to correct those references to that enumerated list of conditions to refer to whatever is established by the Secretary under the authority of the bill. The bill would take effect upon publication in the Kansas Register. And with that, I'd be happy to answer any questions the committee may have.
Good, Scott. Thank you. Committee questions? You did a great job. Thank you very much. As you can tell, I don't do many bills, and so I'm used to the research, so I apologize, Scott, for that. Hopefully, maybe not hopefully, I won't ever get that down pat. So very good. With that, we have via WebEx, we have Carrie Padding, parent advocate. Carrie, are you there?
Yes, can you hear me? Can you see me okay?
Yes, we can.
All right, well, thank you. My name is Carrie Padding, and I'm here today to ask you to support House Bill 2250 because all babies born in the great state of Kansas deserve a healthy start. Newborn screening is truly one of the 20th century's great public health success stories, and it shouldn't matter where you live, all babies should be screened at birth. Newborn screening saves lives and can drastically change the trajectory of life for babies and their families. An efficient and effective newborn screening program is important to me because I became a mom for the first time in November of 2010. A quick and simple test approximately 24 hours after I gave birth to Gavin, the newborn screen consisting of a small heel stick and blood spot test would make a very big difference for us in the weeks and months to come. A few days after we got home from the hospital, we got a call from our pediatrician's office asking us to bring Gavin back in because one of his tests had come back abnormal. And we were scared, of course, sleep deprived, and we complied, and the blood spot test was redone. A few days later, we received the call from our pediatrician confirming the abnormal screen for cystic fibrosis. We were shocked, we were devastated, and had so many questions. What does this mean for Gavin? What do we do next? We were quickly set up with an appointment at the CF clinic in Wichita to have Gavin undergo a sweat chloride test, which ultimately confirmed his diagnosis. After our first care center visit, Gavin began a regimen of inhalers, enzymes, nebulizers, CPT, chest physical therapy, and this is a regimen he continues to this day. I couldn't believe that my 3-week-old baby was eating applesauce off a spoon and taking enzymes with every meal, and he couldn't even hold his head up yet. It took many months to reflect back on our birth and diagnosis story to realize how truly lucky we were that Gavin's first few weeks of life set the course for the best possible health outcomes. And it all started with the newborn screen, identifying his cystic fibrosis. I have several CF mom friends who have older kids who were not screened in Kansas or not screened for CF initially, whose babies struggled with their weight, their health, and other numerous medical appointments and hospitalizations before the real causes of their failure to thrive was identified as CF. It caused significant financial strain for families as well as taking a toll on their emotional, mental, and physical health. I am greatly thankful for the newborn screen and the early detection of Gavin's CF. I believe he continues to grow today because preventative treatments were started prior to symptoms. Very grateful to the support of our CF clinic, the Ascension Via Christi CF Clinic in Wichita, Mid-Kansas Pediatrics, and the Cystic Fibrosis Foundation, who've been with us on the journey since the very beginning. House Bill 2250 allows for all newborn Kansans to continue having the advantage of early diagnosis and metabolic and genetic diseases, which greatly benefit from early treatments and interventions. Please consider increasing the capitation to expand this life-saving and life-changing program to continue to meet the needs of the many families served through this screening program. Our story, Gavin's story, is a personal success story and a public health success story. Gavin's growing and thriving and healthy because of an early diagnosis and treatment, and it all began with a few drops of blood and a hearing test to set my baby on a healthy path. I urge you to support House Bill 2250, and thank you for letting me share my story today.
Very good. Thank you. Thank you for that story. Committee questions? Seeing none, thank you again for being here. Next, we have Palmola Orez and Brian Way. Are you there? Maybe they'll come back. Next, we have Dr. Dina Hubbard, Kansas Chapter, American Academy for Pediatrics. Are you there? Oh, I'm sorry. Okay, Drew Duncan, KDHE. Are you there?
Yes, Chairman Carpenter and members of the committee, thank you for your time and the opportunity to meet with, to appear before you today to discuss House Bill 2250. As mentioned, my name is Drew Duncan, and I'm the Screening and Surveillance Unit Director for the Kansas Department of Health and Environment, which includes the newborn screening and birth defects programs. I'll try to be succinct in summary of our written testimony, but as mentioned, House Bill 2250 amends the existing program statutes, updates some terminology, and requests the capitation for the newborn screening fund be increased to $5 million. The Kansas Newborn Screening Program was established in 1965 PKU. Today, Kansas screens for 34.
Hang on, we lost you. Oh. There you are. You're back.
Do you have us? I apologize. It would happen at an hour and 45 minutes and we have technical difficulties. But again, Kansas is one of only 3 states to provide a universally free newborn screening program at no cost to families or providers. In 2019, nearly 37,000 babies were screened, identifying 20 time-critical or life-threatening disorders, as well as more than 150 severe or life-altering disorders, providing families the opportunity for early intervention. Since 2017, Kansas has added 5 conditions to the screening panel. Kansas expects to add the 35th condition to this newborn screening panel by second quarter 2022. At that point, Kansas will be one of only 9 states who screen for all 35 core conditions on the RUSP, Recommended Uniform Screening Panel. 2 of the conditions added over the last 4 years were only made possible with non-renewable federal grants. With the recommendation for Kansas to remain up to date with the Recommended Uniform Screening Panel, the program will be underfunded and unable to meet growing needs. House Bill 2250 assures the resources necessary to conduct a quality, effective, and robust newborn screening program are available without barriers. It is important to note that House Bill 2250 only requests that the capitation be raised to $5 million and not that $5 million be allocated annually. Again, thank you, Chairman Carpenter and the committee for your time. I'll now stand for questions.
Committee questions. Representative Lynn.
Thank you, Mr. Chair. I'm just curious to know how much it costs to add one typical condition screening, and then also how many are on the secondary panel?
For that question, I'm gonna kick that to Myron Gonzalez. He is our Director of Kansas Health and Environmental Laboratories.
Good afternoon, Representative Lynn and committee. I'm Myron Gonzalez, the Director of the laboratories that does the laboratory part of the follow-up of the newborn screening program. We estimate it varies significantly from disorder to disorder what the cost is, but in general, we kind of use a rule of thumb about $150,000 to $200,000 per disorder. The other thing that is to be considered is that with all of the testing that we do already is every year our costs for the equipment and the supplies continually increases. And that's one of the reasons for the need for the increase of the capitation in addition to adding the new disorders.
Thank you, Mr. Chair. And how many are on that secondary panel?
I don't know. You know the answer.
I don't have a current answer for you, but I can get that. I'll make note of it and get it back to you.
Okay, thank you. I'm just curious.
Very good. Thank you. Committee. Representative Ballard.
I apologize. I do have the answer. It's 23 conditions on the secondary panel. I had myself muted. I apologize.
Kenzie Anderson is our newborn screening program manager.
Thank you, Mr. Chairman. I was interested in those conditions as well. Okay, so in 1965, okay, I think when we started looking at this was the PKU. And not all states, and Kansas did not, within the last, 10, 15 years, didn't do as many as we do now either, right?
That's correct.
Okay, now part of why we didn't do it was the reason, because once you identify them, you have to be able to treat them.
Yes, and I'm not familiar with the full history of what's taken so long to onboard all the conditions, but I do know that more so than just adding it to the panel, there's the entire infrastructure that goes around supporting that new condition, the clinical side, the education and outreach with families. And so there's more to it than just simply adding it to the screening panel.
Well, that's what I remember before, because we were saying, well, why can't we just add this? Because once you do that, then you open up a much broader spectrum and you have to address all kinds of areas. Now, did I hear you correct that it's the most is 35 or is it 43?
35 on the core panel, core conditions on the recommended uniform screening panel.
And so you screened 37,000 babies were screened. What's the biggest problem that you have right now, other than the money?
I think honestly, my assessment is just the increased funding, the ability to grow the services surrounding the conditions, create those partnerships. One of the areas that we're limited in is being able to establish long-term partnerships with just the budget proviso and the increase. Our short-term our full capacity is on short-term follow-up and ensuring that babies who have an abnormal screen are connected to the services, resources that they need. We understand that long-term follow-up is a key piece of a comprehensive newborn screening program, and we just don't have the capacity to do that, to understand what are the downstream effects of identifying these disorders early. We know that it saves the healthcare and the educational system, but we don't fully understand the cost on the Kansas families, negative or positive. And so we really feel like that would be both beneficial to the program and planning, but also in justifying the funding that we receive.
Thank you very much. Thank you, Mr. Chair.
Any further questions? Very good. I think, Representative Concanon.
Thank you, Mr. Chairman. I understand the importance of these, and I'm not disagreeing with any of this. I'm just wondering why this needs to be in statute.
Well, in 2017, the statute, the capitation was placed at 2.5 million, and in 2 fiscal years prior, within the last 5 years, we've come relatively close to exhausting those funds. And so just having that 2.5 cap really limits our ability to grow and expand around these new conditions that we're onboarding.
So we wrote a law that caps your funding for newborn.
Yes, Representative. In 2017, the capitation was added to establish it at 2.5 million.
Well, that just seems real unusual for some of the other testing that's done. Was it? Do you know the purpose of us putting a cap on that? Was it punitive? Were you wasting money?
No, and I can speak to that too. We're very intentional with the funds that we have, and we have a quality improvement approach to the work that we're doing. I think, my understanding, and I wasn't here when that capitation was placed, but it may have been based on prior years' expenditures, which really weren't reflective of our current needs, staffing, turnover, and things like that. And so that I believe that was the basis for why that capitation was placed in.
Well, I just remember having this conversation several years ago in Health Committee, and Secretary Mosher was, Bob Mosher was here, and we talked about all of this being done through rules and regs. And so I'm just kind of surprised that it's a bill, but I don't oppose it. I just don't understand why it has to be that way. But thank you.
Any further questions? I think mainly this bill is to raise the cap and to add a couple of new screening. Yeah, exactly. Okay, very good. Committee, no further questions. I will close the hearing on how, oh, no. Mrs. Juarez, are you there?
I am. My apologies.
Very good. No worries. No worries. I was going to come back to you. Very good.
I appreciate that.
Thank you for being here.
Thanks for having me. I'm just here to kind of touch base on why the implementation of an advanced universal newborn screening program in Kansas is essential. One of the disorders that you guys are looking to add is called Pompeii's disease. There's 2 forms, and my son has infantile onset Pompeii's disease. I'd like to tell you why this would be imperative to kids in the state of Kansas. So I'd like to talk to you about a girl named Annalie. She was born in Alabama, and at 5 months old, she went to the hospital with low oxygen levels. An ER doctor assumed she had a virus, and 48 hours later, Annalie was taken to the ICU and put on life support for over 2 months. Doctors eventually discovered that she had a severely enlarged heart, and that led them down the path to her diagnosis of infantile onset Pompeii's disease. She started to receive the correct treatment and is now 2.5 years old. Unfortunately, because of late diagnosis, she doesn't walk. She can only sit for a limited amount of time unassisted. She doesn't speak and is fed from her G-tube. Unable to potty train, her parents' current challenge is what, if any, preschool opportunities will be available for her next year. I'd like to talk to you about Atlas. At 4 months old, he went in for what they thought was pneumonia. During a chest x-ray, they noticed his heart was enlarged, and the next day noticed he was experiencing heart failure. It was still 5 days later, but he was diagnosed with infantile onset Pompeii's disease. Atlas has began a very aggressive treatment plan to save his life. He's almost 5 now, and he continues to make progress against the many challenges presented from his delayed diagnosis. He receives day-long infusions twice a week. For Atlas, a common cold is life-threatening and means a 5-day stay in the hospital for him and his family. Everyday normal events are a major accomplishment and milestone for him. He uses the assistance of a wheelchair, continues to practice eating and swallowing while still using his G-tube. Unfortunately, these are best case scenarios for clinical diagnosis of infantile onset Pompeii's disease. Even if they're lucky to get a clinical diagnosis at 5 weeks old, it can lead to hearing loss, developmental delays in speech, and need assistance in mobility. I'd finally like to talk to you about my son, Vaughn. He'll be 5 in May. Vaughn walks independently and really thinks he's the fastest runner in the whole entire world. He loves to sing loud. He builds with Lego sets meant for 10 or 12-year-olds. And he loves to play soccer. Atlas and Vaughn are exactly 28 days apart. They have the exact same disease. They're the exact same age. And Atlas actually receives a more aggressive treatment plan than Vaughn does. And yet the difference between their lives is simply that Vaughn was caught at 9 days old and diagnosed through Missouri's newborn screening. Children and families' lives will drastically be influenced by your decision to not only fund, but to add glycogen storage disorders to Kansas's newborn screening. I encourage all of you, please give these children and families a chance, and let's do a better job with our newborn screening. Thank you.
Good. Thank you for being here, and thank you for sharing those stories with us. Committee, questions? Okay, thank you. Thank you again. Okay, we might try Dr. Hubbard again. Is she on? Very good. Dr. Hubbard, are you there?
Yes.
Thank you for being here.
Yes, I apologize for having to step away and come back. Thank you, Chairman and members of the committee, for letting me join you today to talk about the newborn screening, House Bill 2250. It is my pleasure to be here as a pediatrician, a neonatologist, and public policy chair for the Kansas chapter of the American Academy of Pediatrics. Most babies are born and do fine at birth, but there are a small number that, even though they are well appearing, have something very serious going on. And it's only with newborn screening that we can try to identify these patients soon enough that we can make a difference, that we can prevent death, that we can prevent disability and severe problems. And while technology and science advances and grows exponentially, we need to be able to stay up with the recommendations as a state. And so that is why on behalf of the Kansas chapter of the AAP, we support this bill to remove a cap so that we can adjust and adapt like we all are doing these days, adapt as we need to provide the very best care for our patients. I will tell you that just in July, had a baby that was admitted, was born on a Monday. On Friday was seen at the pediatrician's office, and no complaints from mom, but they noticed that the temperature was low. And the doctor checked the newborn screening, and it was in fact abnormal. And the baby was admitted, had a problem called MCAD. And if that baby had not been diagnosed and sent to the hospital, gotten the protein and carbohydrates they needed on a very continuous to frequent basis, that baby would have died over the weekend. That was just one example recently. We also recently had some twins that were premature, feeding, growing, the normal newborn course in the neonatal intensive care unit, and their newborn screens came back abnormal, and it required a change in their diet. So there are little things that we can do that can make such a big difference. So we just don't want to limit any of that. Newborn screening includes not just the blood test, but also hearing, and then the critical heart screen for congenital heart diseases. And it's about once a month that I have an admission into the neonatal intensive care unit of a baby that would have gone home and would have gotten into trouble, very possibly died, like they often did, even as early as 15 years ago. And now, because we just checked their oxygen level in their right hand and in one of their feet, we can recognize a problem, get them to a center to get what they need, and identify that heart lesion. So